Good morning and welcome to the 4th Melbourne Institute Virtual Colloquium. Today's colloquium considers whether hospitals should receive additional payments for treating patients who are socio-economically disadvantaged. This colloquium is part of a series created to provide insights that help us better understand and analyse Australian economic and social policy, based on the research and expertise of Melbourne Institute researchers. My name is Roger Wilkins and I am the Deputy Director of the Melbourne Institute. Let me extend a warm welcome to you all. Let me also acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Before I introduce my colleague, Associate Professor Jongsay Yong, let me explain the format of today's session. We've asked Jongsay to speak for approximately 20 minutes, following which there will be time for him to address your questions and comments. I will then ask our reactor, Ms. Tanya, to comment and provide her insights, after which there will be time to address further questions from the audience. To handle questions and comments, we are relying on the Q&A function found at the bottom of your screen. You can submit questions at any time through this function, and I encourage you to do so. Now, I'd like to introduce our speakers. Associate Professor Jongsay Yong is a Principal Research Fellow in the Melbourne Institute of Applied Economic and Social Research at the University of Melbourne. Jongsay holds a PhD in Economics from the University of British Columbia, Canada. He joined the Melbourne Institute in 2002, specialising in empirical research on health economics and industrial economics. He has conducted numerous projects on health services utilisation in the context of Australia's mixed public-private health system. He has had extensive experience analysing hospital administrative data, especially the linked admitted patient data from Victoria. Let me also introduce Tanya. Tanya joined the Commonwealth Department of Health in 2015. With a background in social, environmental and economic policy, Tanya has over 20 years of experience as a leader in the Australian Public Service. Tanya is currently the Deputy Secretary of the Health System Policy and Primary Care Group, and is responsible for strategic matters across the portfolio, including hospital funding, international engagement, and Commonwealth-state relations on health matters. She is also responsible for leading the department's work on policies and programs relating to mental health, primary care, health economics and research, and Aboriginal and Torres Strait Islander health. Her achievements include leading the negotiations for a new National Health Reform Agreement, heading up the Victorian State Office for Health, establishment of the Indigenous Australians Health Program, representing the Australian Government at the United Nations World Congress of Indigenous Peoples, and the United Nations Committees on the Convention of the Rights of the Child and the Convention on the Rights of Persons with Disabilities, and leading the environmental response to the Montara oil spill in the Timor Sea, and heading the Forest Review Task Force. Tanya will provide her experience and insights to fully inform our exploration of the research and analysis that will be presented by Associate Professor Jongsay Yong. With that, I'd now like to invite Jongsay to speak. Jongsay.
Thank you, Roger. Welcome, everyone. So let me put the slide on. Right. So welcome again. Good morning to everyone. So today we're talking about hospital funding and the role of socio-economic status of patients. Before I start, I would like to acknowledge the contribution of my co-author, Dr. Yong. We wrote a joint paper a while ago. The paper is currently under review, and this presentation will be based mostly on that paper. Now, we would like to acknowledge the funding support from the Victorian Department of Health and Human Services, which also provide the data for this analysis. Of course, the departments may or may not agree to what we say today. The views expressed here and in the papers are ours and ours only. All right, with that out of the way, let's get started. So in Australia, public hospitals are mostly funded based on volume. In other words, of course, it's case mix adjusted, but essentially it's a volume-based funding system. The more patients hospitals see, the more funding they get. Now, this sort of funding system is okay. It's good for trauma. It's like, you know, somebody have or acute care, somebody has appendicitis. They get to the hospitals, hospital fix them up and don't see them again. But this is really not great for managing chronic diseases. Somebody like having diabetes and so on. So for these patients, you don't want them to end up in hospitals. But the problem with this volume-based funding system is that hospitals don't see the patients until they end up in hospitals, by which time often it's too late to avoid the worst outcomes. Now, it would be all right if chronic diseases are not really that common. Unfortunately, that's not the case. With longevity and aging of the populations, chronic disease, it's becoming more and more common. At the moment, from data from the Australian Institute of Health and Welfare, about 1 in 4 Australians have 2 or more chronic conditions. And this is going to get worse, obviously. So current funding system has a problem. It doesn't provide any financial incentives for hospital to try and keep patients out of the hospitals. Hospital only get funding if they see the patients. Obviously, the funding system doesn't give us ideal health outcomes, and also it doesn't use health resources in a good way. So some sort of funding reform for managing chronic diseases become necessary. One popular funding models is capitation funding for chronic diseases. So this sort of funding models essentially just pay a lump sum to providers. When providers enroll a patient in the program, they get a lump sum, and then they decide how best to spend that lump sum for the care of the patients. So obviously the incentive, it's more aligned in this sort of setting. There are many trials and examples of this sort of capitation funding. In Victoria, there's this Health Links trial, and there's also the healthcare homes trial by the Commonwealth, which look at GP care. Now, the question is, if we were to move to capitation funding for chronic diseases, how should socio-economic status be allowed for? And if we want to allow for it, how much should we allow for it? And this is the questions that we are trying to address. There's some evidence that SES disadvantaged patients tend to use more hospital services. And that is from international evidence as well as from Australian evidence. Now, the problem with this funding system is that if there is no allowance for SES of patients, some hospitals which serve more disadvantaged patients because they're located in areas where there are more of this sort of patients, then they will be disadvantaged in the sense of they will be underfunded if we don't allow for SES. Now, in extreme cases, they may even engage in patient selections like cream skimming or transfer patients with low SES to other hospitals. So then you end up low SES patient end up being like a football being kicked around. That's not a good scenario we want to see. Now, SES is known to affect health. There is ample evidence about the income health gradient in the literature. Low SES people have high prevalence of, for example, cardiovascular disease and diabetes. These are well established in health economics and also in health services research. There's much less agreement on how SES affect healthcare use. More health needs don't necessarily translated into more healthcare use. There's a lot of other factors that come into play here, things like funding, insurance, supply, and how health services are organized. These all affect access and utilizations. Now, related to this literature is a large literature on measuring inequity in health and healthcare use. Two concepts kind of are relevant here, and we'll come back to this later on when we confront the data. One concept is horizontal equity, which says that the people with equal health needs should have equal use. So that's kind of obvious. The other concept is vertical equity. So people with unequal health needs should have unequal but equitable use. Now, this is a bit difficult when you try to operationalize this concept when you confront the data. We'll come back to this. Now, I should mention that equity is one kind of important principle for the Australian healthcare system. This is the way our healthcare system is organized. Equity is a very important principle. Now, this is the obligatory COVID slides. What's the implication of COVID on funding and funding reforms? Funding reforms, I should mention at the outset, it's a long-term and very complex process. It is a process that tries to make continuous adjustment and improvement to address issues arising from the current funding model. Whether we have COVID or not, the fact that the current funding model is not ideal for managing chronic disease will remain with us. Now, we know COVID affects economic activities and health, and we have some early evidence that this is especially severe for low SES people. And what it means is that from the income health gradients, we can predict that low SES people will suffer worsening mental and physical health because of COVID. What it means down the road is that we will likely see increased demand for care from low SES people. But we also know that supply of healthcare services won't be great because governments are obviously facing huge deficits and huge government debts everywhere. So if you put the two together, the picture won't be pretty. And funding reforms seems to be a place that you want to start soon. Otherwise, down the road, we're going to have huge problems with the health system. Now, what we do here in this paper is we try to quantify how SES affect hospital use and in-hospital adverse outcomes, and we focus on chronic disease patients. Our results will try to illustrate differences in use and also in adverse outcome between different SES groups. And what we hope to do is, we hope to inform policymakers who plan to introduce SES loadings in their capitation funding schemes. Now, the first task, of course, is to try and classify patients or group patients into SES groups. SES reflects absolute and relative position in society. So it usually includes things like income, education, wealth, employment, and so on. We obviously don't have detailed data on these sort of things from patient data. So what the department staff did was they classified patients according to whether they use human services and health services, so according to their records. So using that, they classify patients into 4 groups. Group 0, these are people who don't use human services or health services that are related to disadvantage. Group 1, these are low disadvantaged people using human services, health service not linked to SES or not SES specific. Group 2, these are people with moderate disadvantage. They use health services or human services, but these are universal services and not really SES specific. And group 3 are people with high disadvantage. These are people who use services designed for people facing SES issue, or these are restricted services that are restricted to only low SES people. Now, because of some of these services that are quite confidential in nature, so privacy concerns prevents us as researchers to access those detailed data. So we basically have to rely on staff at the Department of Health and Human Services to do the classification for us. So we don't quite see which type and the nature of services and how the classifications are made. But we do know that the departments manage a range of health and human services. This includes disability support, family assistance, and so on and so forth. Now, you might imagine that once we get the classification done, then we can just look at the use of hospital care by different groups of SES groups. Unfortunately, there is a problem. Things are not that simple. Now, we simply measure outcomes of patients in different SES. We will likely be comparing apples and oranges, and that won't be very fruitful. One big concern is we're going to capture patients at different stages of a disease. And those who are at the late stage obviously going to have high use compared to those at the early stage. So in that sense, we have to apply both the notion of vertical and horizontal equity. Remember the notions we mentioned earlier. So when we come to the data, we have to apply the notion that there is really not many good ways of trying to handle horizontal, handle vertical equity. So what we do is, I'll show you a picture of what the problems look like. So on the x-axis, you have time. So somebody is first diagnosed with a chronic disease. On the y-axis, that's the utilizations. So the profile use is usually like this. So at some point, the patient died. So before the patient died, usually there's very heavy use. Before that, the use is usually quite low. So because our data only capture the patient at the point in time, we might capture the patient at this point in time, or we might capture the patient at this point in time. So if you compare these two patients, not going to be very meaningful because they are at different stages of the disease. What we want is to compare patients during their first year of the spell, of a disease spell. So they are all placed on equal footing. Now, if we have enough data, we can compare the patient in the second year of the spell and the third year of the spell and so on, provided we have long enough data. So we need to define what the spell is. A spell has to satisfy two conditions. Obviously, the patient must have one of the chronic disease that we are interested in. Later on, I'm going to show you a list of all the chronic diseases that we study. And the second requirement is that during the previous year in the record, in other words, the previous 360 days or longer, the patient was not admitted with a principal diagnosis of that chronic disease. In other words, we have a look back period of 12 months, and within that 12 months, the patient was okay. So then we say that the patient start a fresh spell started from that date. Now, obviously, 12 months look back period isn't ideal, but because we only have 3 years of data, so that's what we will do. With longer time series, obviously we can look back longer. Now, once the spell, a spell is defined and we identify the start of a spell, then we can look at outcomes. So we got 3 measures of healthcare use and 3 measures in hospital adverse events. These are quite common measures. The first measure of healthcare use is total cost during the entire spell. And the second is total length of stay during the entire spell. And third is total number of admissions. So I should emphasize that a spell can have multiple admissions. And the measure of in-hospital adverse events are readmissions, unplanned readmissions, number of episodes with hospital-acquired complications, and number of potentially preventable hospitalizations. So let me talk a little bit about the data. The data is the Victorian admitted episode data sets. This is admin data. They are linked to 12 different human services utilization records. In total, we have 7.5 million separations or discharges, and it covers 3 years, 2013, 14 to 15, 16. So about 1.7 million separations were from users of human services. And we first identified patients with selected chronic diseases and then next define the spells for these patients. And only patients with defined spells are retained in our sample. And this is how our samples looks like. We have by far the biggest group is digestive system disorders, followed by heart disease, and then followed by kidney disease. You can see diabetes is somewhere down in the middle, and then there's schizophrenia, dementia, and so on. Now, this is the means and standard deviations of this outcome measure, of these 6 outcome measure by SES groups. There's a lot of numbers to look through. So what I'm going to do is just show you pictures of 2 of these. So the first picture is total cost by SES. SES groups are no disadvantage, low disadvantage, moderate disadvantage, high disadvantage. So on the y-axis are thousands of dollars of cost. The second picture is about complications, hospital-acquired complications. If we look at both cost and complication, you can see 2 different sort of, you can sort of divide them into 2 different categories or groups here. The high users are the moderate and high disadvantage groups. The low user are those with no disadvantage or low disadvantage. Now, similarly with total cost and with hospital-acquired complications. So that sort of patterns kind of you'll see for all the other outcome measures we have. Now there's a dip here from moderate to high disadvantage. We believe this has to do with access. So high disadvantage patients may have limited access for whatever reasons. Now, obviously those are not control for anything. We try to control for the user using regression analysis. The controls are age, gender, marital status, rurality, and so on and so forth. We have a couple of fixed effects trying to control for disease and hospital fixed effects. Now, these are the estimated results. Again, lots of numbers, so I'll try to show you in picture. These are the estimated effect of SES on total cost. The reference category is people with no disadvantage. These are low disadvantage, moderate disadvantage, high disadvantage. Now, the estimated point estimate is people with moderate disadvantage roughly incur $3,000 more than people with no disadvantage in terms of total cost, and people with high disadvantage incur about $2,500 of cost. And this sort of patterns we'll see again in other outcome measures. So these are two other utilization measures in terms of length of stay and in terms of number of admission episodes. You can see here that the high and moderate moderately disadvantaged groups are the ones that have longer stays and also have more admission episodes. Now move on to adverse events. Again, similar kind of pattern you see before. In terms of number of hospital-acquired complications, the high and moderate disadvantaged groups have about 0.05 to 0.07 more complications. Obviously, complications are not a very common thing, so it's a kind of very small number here, which is what we expect. Now, the other pictures are fairly similar. These are the estimate effect of unplanned readmissions. Very similar, high and moderate disadvantaged patients have about 0.06, 0.07 more readmissions. This is the picture about potentially preventable hospitalization. Again, similar pattern as what we see. So let me try and summarize what we find. We look at how SES affect utilization and adverse outcome of hospitals. And what we find is that in terms of chronic diseases, they have very significant and material effects. In terms of total costs, they cost about $2,500 to $3,000 more per year in terms of total cost of utilizations. What this implies is that hospital funding should try to take into account SES of patients. Otherwise, hospitals serving areas with large number of disadvantaged patients will be underfunded, and this won't be ideal. The funding shortfall is going to be especially severe if we implement capitation funding, because that sort of under that sort of funding schemes, hospitals are paid an annual lump sum to take care of the patients. With COVID, this sort of funding reform should become more pressing, because COVID it's affecting disproportionately SES disadvantaged populations. I'll stop here. Thank you.
Thank you, Jongsay. So we've got time for a few questions before we move on to Tanya. One question that's come through is, to what extent could the higher costs, or could capitation funding address the issue you're identifying through just having a more refined formula that, for example, could take into account things like comorbidities and severity in the funding formulas, rather than because it sort of seems like SES might be being used as a proxy for those sorts of factors, rather than SES itself being the cause of the higher costs. So is there scope for capitation funding to just be more sensitive to overcome the problems you're identifying?
Well, I think the issue with funding, especially in terms of funding of chronic diseases, is really the incentive effect. So we want to keep people out of hospitals. We don't want them to end up in hospitals. So that's the incentive aspect of the funding system. Now, obviously, we know that low SES people have greater health needs. So as a society, we want to have an equitable distribution of healthcare resources. In that sense, we should distribute more resources to low SES patients. So that's kind of consistent with this view. Now, whether SES is a proxy or not, I don't know. I mean, we have ample evidence that people with low SES tend to have worse health outcomes. higher health risks, and so on.
Okay. Another question is, to what extent do the differences across SES depend on how SES is grouped into the 4 categories? Did you look at different types of SES classification?
So this is really beyond us. As I mentioned in the presentations, the classification is done by the Department of Health and Human Services. So because of privacy concerns, we have no access to the human services records. So we don't know who are using what services and how they get classified. So in other words, we kind of have to trust what the department staff know what they're doing. So we have no, there is no possibility for us to try and test the sensitivity of this classification.
You mentioned, well, your analysis showed that costs were actually higher for the moderately disadvantaged than for the highly disadvantaged. And you mentioned that, well, your hypothesis was that reflected poorer access to healthcare for those in the most disadvantaged group. What would be the reasons for that? Is it because they tend to be in regional areas or not close to services, or is there some other explanation for why their access might be lower?
Regional area is one possibility. The other ones, remember, we don't know what sort of services, what sort of problems these people have, because we don't know how they get classified into different groups. So my guess is that possibly linked to things like homelessness, mental health. So we know that people who are homeless and having mental issues may not seek health care as much as people who are less fortunate. So this could be, and including what you mentioned about regional area, this could be the reason why they have lower access.
Okay, now there are a number of other questions that have come through, but hopefully we'll be able to come back to at least some of those after our reactor, Tanya Rishnu, has spoken. But I'd now like to invite Tanya to speak. And I believe, Tanya, you're accompanied by Bronwyn Field, who is an assistant secretary in the department. But if I could now hand over to you, Tanya.
Hi, can you hear me now?
Yes.
Thank you, and thank you for the opportunity to hear the results. I am joined by Bronwyn Field, who's acting First Assistant Secretary in the Portfolio Strategies Division that also has responsibility for hospitals and the National Health Reform Agreement. Look, can I first start by acknowledging that wherever we are today, we meet on Aboriginal land and pay my respects to elders past and present. And just reiterate that these are my views and my reflections on the research that we've just heard. And thank you, Jongsay Yong, for that presentation. But just to reinforce that these are my reflections rather than the views of government. I think that the research actually presents fairly clearly the complexity of the health system and the complexity of the issues that we're dealing with in terms of health systems, hospital funding, but also primary care. And I would, while the reflections in the research and the findings show that our funding formula is based on activity, there is coding for complexity. So it should pick up some distinction in terms of complexity of conditions presenting to hospitals and the funding's adjusted accordingly. But it is a complex funding system, it's a complex coding system. And we have the National Health Funding Body and the Independent Hospital Pricing Authority that are actually tasked with a lot of that complexity. Having said that, I think one of the things that we're certainly looking at, not just in terms of hospital funding and the recently signed National Health Reform Agreement, which will go for the next 5 years and brings together a federated model of health system funding, is the National Health Reform Agreement actually recognises some of that complexity. And so some of the changes that you'll see when you look at that agreement over the next 5 years are key areas of long-term health reform. Those include joint planning and funding and commissioning. And as part of that, I think, Jongsay, you mentioned health links in Victoria, but there's a range of hospital in the home outpatient services that we're looking at and evaluating in that context to see how do we provide better services through hospitals and actually keep people out of hospital where we can and avoid admission and avoidable admissions. The other thing that obviously the research alluded to but didn't pick up directly because of the research focus is the role of primary healthcare in making sure that we're trying to address complexity, comorbidity and chronic disease early and prevention. So we can't, I guess, look at hospital funding in isolation from broader health system funding and primary care. There's a couple of examples. We've looked at health links, we've looked at health hospital in the home and various models. You mentioned healthcare homes, which for those who aren't familiar with it, is really looking at a blended funding model at a primary care level that looks at funding for particularly chronic disease and enrolment measures. And more we're looking at how do we provide access and quality of care at a primary care level, building a relationship with a general practice and making sure that we're looking at holistic approaches to particularly chronic conditions, but patient care. Some other models, obviously the way that we fund Aboriginal community controlled organisations, it's a blend of blended funding, block funding and capitation. And so that gives us, you know, different levers that we can look at, and particularly when we're looking at Aboriginal and Torres Strait Islander people and closing the gap issues about how do we provide different blended funding models that might improve outcomes overall. And some of the other things to note that I reflect on is under the recent National Health Reform Agreement, we've also tried to provide, I guess, a more level playing field and not have any perverse incentives that might drive hospitals to treat private patients differently to public patients. So things like that. In the context of COVID, the government's provided a minimum funding guarantee for private hospitals to make sure that we've got the whole of health system capacity to draw on where and how we need to, and working with the states and territories really closely about making sure that, you know, we're managing the system holistically and we're providing enough certainty and surety to be able to treat patients where and how we need to. So reflecting on the fact that, you know, I think the research points to a lot of live issues that have vexed governments both at state and federal level for a long time, but that we have looked at different models and we're in the process of looking at which of those models is best used for taking into account socio-economic status, health status, complexity of conditions, chronic conditions. The other reflection I'd make, and once again, the research and the presentation pointed to some of the tensions that we wrestle with on a regular basis. And one of those is how do we align risks and benefits? So we talked a lot in the research about incentives. How do we make sure that there's not creaming? How do we make sure that we set the performance indicators at such a level and with the right kind of incentives built in so that you don't get creaming of patients, so that you don't get hospitals making choices about who they treat based on risk, and so that you get alignment of risk and benefit. You mentioned privacy. Privacy is paramount in the health system, and even just aligning SES data, social security data, and health background, history, complexity is tricky, and we take that very seriously, and it's not easily done. So how we address low SES in a privacy context is, you know, a complexity for us. Data, an improvement of data and an integration of data between state, federal systems, and then social security and health systems continues to be an area that we work hard on. And we work closely with the AIHW and the states and territories in continuously refining that health performance framework. And the final point that I'd make at this point, and then I'll open it to questions, is one of the most challenging things, I think, for us, and moving to looking at how you might weight and how you might fund differently, is everything points to an outcomes assessment model, and setting what outcomes you measure, how much control the health system has over those outcomes, and how you reward or incentivise or avoid that gaming effect is paramount. So more research around how you set better outcomes measurement in a health system, and particularly for hospitals, is always something that we're interested in working on. So look, thank you so much for sharing the research. And when there are some really interesting insights in there, particularly around the moderate disadvantage compared to the severe disadvantage differences. And I think you touched on that question earlier, you know, issues of health literacy, issues of complexity, and you mentioned homelessness and security and food security, and all of those issues I would imagine play into that, but untangling that is quite complex. But the big surprise for me, and what I wasn't expecting, is the digestive diseases coming top of kind of that ranking. You know, cardiovascular, diabetes, COPD, all of those come up routinely, but digestive diseases was an interesting point for me, and I think we'll take that away and look more closely at that. So that probably kind of at least provides an initial response, but happy to take some questions.
Thank you, Tanya. So Jongsay, could I invite you to join back in online?
Yep.
Great. So perhaps firstly, do you have any responses to the reactions from Tanya? Is there anything you'd like to add?
Yeah, just want to pick up the point on the current funding system, which does allow for Aboriginals and Torres Strait Islander status. So that's kind of a recognition that SES it's playing a role here in terms of utilizations. So I just wonder, how far is it from here that we do allow for other kinds of disadvantage?
Look, you're absolutely right. We do take into account Aboriginal and Torres Strait Islander status and complexity, and take that into account in funding models. I don't think it's a huge leap, and we already do weight the system, as I said, for complexity. We do things like weighting for rural, regional, remote access as well. So I don't think it's a big step, but having said that, any complexity, any added complexity in a funding system needs to be outweighed by the risks.
So we've got a few questions, I guess, around this capitation funding model, and I suppose just the desirability of it. And I think, Tanya, you mentioned that it's sort of one, it's one of several ways in which fund. So it's not that the Commonwealth relies on this model alone in isolation. That, but you know, to what extent you know, should we have capitation funding at all? Is there an argument for alternative approaches? So someone has mentioned Sweden has introduced a bundled payments for particular chronic conditions, and the payments are stratified across 4 SES levels. Is that likely to be preferable to having any sort of capitation funding involved. Maybe I could start with Jongsay and then Tanya.
Yeah, I mean, it comes in different names, but the essential feature is that it is sort of decoupled from the volume-based fundings that we currently have. So it can take many different forms. The essential feature of the capitation funding is that it doesn't depend on volume. It is kind of a lump sum payment system. Based on just patients showing up to the registered into the program. So there are many different design features you can build into that. So I'm sure Tanya will have more to say. So over to you, Tanya.
Thank you. And I think it points to the complexity. There's a range of different models internationally, and as I mentioned, domestically, that take capitation into account. But one of so funding in a capitation model, funding through block funding, relies on setting really clear outcome measures. So what is it that you want to achieve by providing funding and flexibility is reliant on being really clear about what outcomes you're expecting and avoiding that gaming of the system that says, great, if I'm provided, for example, with block funding to improve someone's, a patient cohort's blood sugar level, for example, I don't want to create a perverse incentive for, a hospital or a practice to only take the healthier people. So you need to balance it with risk, you need to balance it with really clear outcome measures, and you need to make sure that you remove those perverse incentives from the system, but also not overly complicate all of the measures and all of the data we're collecting. The other common refrain we hear is how much the health system is responsible for some of those outcomes. And so once you head into areas like social determinants of health, someone's housing status, someone's educational level, someone's employment status all feed into that. And how much can the health system respond to that and be accountable for those outcomes is also one of the live debates that we continue to have.
Well, we have run out of time, and unfortunately we've received many more questions than we could answer in this session. However, we will be posting all the questions received on our website, and Jongsay will endeavour to answer all of those questions, so that there will be an opportunity to have you to go online and view answers to your questions. Once again, thank you, Tanya. Thank you, Jongsay, for your presentations. I hope you've enjoyed this colloquium, and we look forward to seeing you at our next colloquium on the 6th of August, when Dr. Kane Polidano will be presenting on the value for policy research of using tax filer information from the dataset known as A-Life. I encourage you to register for one or more of our upcoming colloquia. The link to register can be found in the chat function at the end of this event. Thank you and goodbye.
Thank you.
Thanks, Tanya.